बिस्मिल्लाहिर रहमानिर रहीम। रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वाहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। I am Dr. Mudassir Associate Professor, Sahara Medical College, Narawan. In the previous lecture, we have discussed about the movements of the chest wall, buccal-handed movement and pump handle movement, and movements of the diaphragm, which are causing expansion of the chest and in return expansion of the lungs, and which is increasing anteroposterior transverse as well as longitudinal diameter of the chest wall. Now today we are going to see the muscles which are helping in increasing the diameters and movements of the chest wall. First of all, there are some accessory muscles of respiration as shown here in these slides. These muscles are primarily concerned with the upper limb. They are attached from the thoracic wall to the upper limb. And most of the movements these muscle causes, they are concerned with the movements of the upper limb. But many of them, that is pec major, pec minor, serratus anterior, they also act as accessory muscles of respiration when needed in forceful inspiration and expiration. And I have discussed with you people that during this process, what the person do is that they hold something with their hands, or you have seen that the athletes, they put their hand over their knees so that the upper limb movements are fixed. Now the muscles which are basically concerned with the movement of the upper limb, when they contract, they fixes the upper limb, and they then will help in the movement of the chest in forceful inspiration and expiration. Similarly, the scalenes muscles, which are actually the muscle of the neck, and they descend from the vertebra to the neck, first and second rib, they are primarily the muscles of vertebral column. But during the fixation of the first and second rib in forceful inspiration and expiration, they help in fixing the first and second rib. Now here we see the accessory muscles of respiration, the scalenes muscles, pec major, pec minor, serratus anterior. Along with that, there are muscles of abdomen which are also attached to the ribs, that is the rectus abdominis and external oblique, which also help in fixing the rib during forceful inspiration and expiration. Now here we see the table showing the muscles of thoracic wall. First of all is the serratus posterior superior, which originates or is the superior attachment with the knuckle ligament spinous process of C7 to T3 vertebra. Is the superior border of second and fourth rib where there is inferior attachment. Innervation is by the second to fifth intercostal nerves, and their main function is the proprioception, but they help in elevating the rib also. The other muscle, serratus posterior inferior spinous process of T11 to TL2 vertebra, and the inferior attachment to the inferior border of the 8th to 12th rib near their angles. Anterior rami of T9 to T12 thoracic spinal nerve supplies this nerve. They are also mainly concerned with the proprioception, but they also help in the depressing the ribs. Levator costrum, similarly arises from the transfer processes of T7 to T11, and it is attached between the tubercle and angle inferiorly, but this muscle, levator costrum, is supplied by the posterior rami of C8 to T11. Mind it is the posterior rami. Posterior rami. It elevates the ribs. Other muscles, external, internal, innermost intercostal and subcostal muscle. They are muscles of the intercostal spaces and also the transverse thoracic muscle, and their attachment is with the ribs, sides of the rib, and then there is main is to elevate and depress the rib in central parts, and their whole nerve supply is from the intercostal muscle. Now we come to individual muscles. Here we see in this slide, here is the serratus posterior superior. You are seeing is arising from the knuckle ligament and up to T1 and T2. This T1 vertebra is arising and attaching to the ribs. Serratus posterior superior. Here you see the muscle that is the serratus posterior inferior from the T7 to T11, T11 and downward, L1 vertebra to L1 vertebra, serratus posterior inferior, and you seeing is distal attachment with the ribs. So these two muscles are important in proprioception, the main function, and elevation and depression of the ribs. Now, the very first muscle of the intercostal space is the external intercostal muscle. Here you see the external intercostal muscle. You can see that it's from the upper border of the lower rib to the lower border of the upper rib, and here you see the fibers directed, most superficial muscle directed downwards and forwards. And from the inferior border of the rib above to the superior border of the rib below its attachment. And this muscle extend forward up to this point, that is costal cartilages, where it is replaced by from this point to the lateral border of the sternum, replaced by the anterior intercostal membrane or external intercostal membrane, because it is part of external intercostal muscle. Second muscle is the internal intercostal. You are seeing here the muscle external intercostal is fibrous, running downward and backward from the subcostal groove of the rib above to the upper border of the rib below, and this muscle extends backward here in this area, that the backward up to the vertebral column, but it extends up to the angle of the rib behind, and then it is replaced by the posterior intercostal membrane or internal intercostal membrane. So anterior intercostal membrane is part of the external oblique, and posterior intercostal membrane is part of internal oblique muscle. Now the innermost intercostal, it is not a continuous muscle, it is divided into parts, three parts. Here we see one muscle posteriorly, subcostal muscle, rising from the rib, one rib at the tubercle and the neck of the rib, and extending towards the upper rib, subcostal muscle. Other part is located anteriorly from the sternum to the ribs, sternocostalis or transverse thoracic muscle. And the third part is on the laterally present, which is named as innermost intercostal muscle. So, deepest layer, an incomplete muscle layer, crosses more than one intercostal space you can see that this muscle here is crossing one and more intercostal space anteriorly, and it is related internally to the endothoracic fascia and externally to the intercostal nerve and vessels, and uh, and parietal pleura and externally to the intercostal nerves and vessels, divided into three portions which are separated from each other. So anteriorly is the transverse thoracis, posteriorly is the subcostalis, and laterally it is the innermost intercostal muscle, three parts, and between these muscles separate by endothoracic fascia from the parietal pleura, and between this muscle and internal intercostal runs the intercostal nerves and vessels. We can see here in this slide, in this diagram, that here is the intercostal vessels and nerve, vein, artery and nerve. They are running between the innermost intercostal and internal intercostal. Internally will be the endothoracic fascia, which separates the innermost intercostal from the parietal pleura actions. The intercostal muscles can raise the second to 12th rib towards the first rib as in inspiration. So here what we understand, the first rib will be fixed. The muscles, they will be pulled towards the first rib, but the ribs, they will be from second to 12th rib, they will be raised towards the first rib. First to 11th ribs will be lowered by the contraction of intercostal muscles as in expiration. So in this, the 12th rib will be fixed and the ribs will be pulled towards itself. Nerve supply, intercostal muscles are supplied by corresponding intercostal nerves. So here we see how they depress the rib, and here see the direction of the fiber. A is the external intercostal muscle. B is the internal intercostal muscle. And C is the internal intercostal muscle, interchondral part. Internal intercostal, because anteriorly is posteriorly that the internal intercostal muscle is absent and replaced by the membrane, but anteriorly the fibers are present, and they will A plus C means external intercostal, and the interchondral part of the internal intercostal, it will elevate the ribs. And the B part here, that between the part of internal intercostal muscle, between the two bones, the bony part of the ribs, this will try to depress the ribs. It's also common sense that when A will elevate, B will depress the rib. So here are shown the muscles of some accessory muscle as well as the intercostal. Here you can see external intercostal muscles in the cadaveric vein. You will see here will be the external intercostal muscle. The fibers are running downward and forward. At this place, it will be replaced by the anterior intercostal membrane, and when it is removed, you can see the neurovascular of internal thoracic. And here is shown the transverse thoracis part of the innermost intercostal from the sternum to the ribs. Rectus abdominis part from the which is attached to the refit process, and the seventh costal cartilage or the costal margin, and here also external rubbery originating from the 7th, 8th, 9th, and 10th. And pect major cut end has been shown, accessory muscle of respiration, and also here is the pect minor muscle has been shown here. So in this slide we can understand there are also small muscles of the neck region which are also attached to the upper end of the manubrium, upper border, sternothyroid and sternohyoid, but they are not basically concerned with the movement of this, the chest wall. Sternocleidomastoid is also inserted over the upper border of the sternum. Manubrium sterni, superior border of the manubrium sterni. From inside has been shown here, from the sternum to the chest wall. Here are shown the muscles. These muscles, they are transverse thoracic muscles, and you are seeing here that the internal thoracic artery and nerve, they are running downward between parietal pleura and the transverse thoracic part, and they are running between the vasothoraces and internal intercostal. Then they will reach, these neurovascular bundle will reach up to the diaphragm, where the artery will divide into two branches, internal thoracic artery and vein. Here we are seeing the origin of internal thoracic artery from the subclavian artery. Is the origin of internal thoracic artery from the subclavian artery. Now is the diaphragm, platform, which is separating the abdomen from the thorax. It's a Greek word, throw apart, separate the two things, thorax and abdomen. Fibromuscular sheet separates the thoracic cavity from the abdominal cavity, performs an important function in the respiration. Now its origin is different. It's three parts origin in, because it's not a quite circular, it's a oblique one. Three part: sternal part, costal part, lumbar part, and also the lumbar from the medial lumbosacral arch, lateral lumbosacral arch, right crus and left crus. Here first we see the sternal part from the two flashes from the back of the xiphoid process. Costal part arises from the inner surface of the cartilages, adjacent part of the lower six on each side, interdigitating with the transverse thoracic abdominis muscle. Lumbar part from the medial lumbosacral arch, tendinous arch in fascia covering the psoas major, medially attaches to the side of the body of the L1 vertebra, laterally attached to the front of transverse process of the L1 vertebra. Then the lateral lumbocostal arch is tendinous arch in the fascia covering the upper part of the quadratus lumborum, medially attached to the front of transverse process of L1 vertebra, laterally attached to the lower border of 12th rib. Then there is the right crus arising from the anterolateral surface of the bodies of upper three lumbar vertebrae, right one, upper three lumbar vertebrae, and intervening intervertebral disc. The left one corresponding upper two lumbar vertebrae. So this is the difference between the right crus and the left crus. Right from three lumbar vertebrae and left one from two lumbar vertebrae. The medial margin of two crura forms the tendinous arch across the front of aorta, the median arcuate ligament. So here we see in this diagram. So this is the sternal part from the xiphoid process. Then there will be the costal part from the sixth rib and costal margin. You can see here interdigitating with the transverse thoracic muscle. Then you come and go back up to the here. From posteriorly you can see that first of all there is this one, the fascia over the Psoas major is the medial longitudinal, medial lumbocostal arch. From here, the diaphragm is originating. Here is the L1 vertebra, transverse process of the L1 vertebra, and laterally up to junction of this is the uh, lateral lumbocostal arch, thickening of the fascia over the quadratus lumborum. From this margin arising the lateral part of the diaphragm. This level will be below the L1 and L1 vertebra, and here laterally it will be over the 12th rib. So in this way, completing the diaphragm. So here we can see. Here is you can see the right crus of the right crus, left crus. Right crus will be, this is the right crus from the upper three crus, and the left crus will be from the upper two vertebrae. Here you can see these are arching over the fibrous arch which is running over the anterior surface of aorta. Here are shown the openings in the diaphragm. So this is the fibrous part of the diaphragm. This is the muscular part of the diaphragm. This is the tendinous insertion of these muscular fibers. Centrally, they fuse into the central tendon of the diaphragm. Insertion will be a trilobular in shape, 3 leaflets, middle leaflet triangular in shape with its apex directed down toward the Ziphioid process. Here you can see. Right and left leaflets tongue shape, curved laterally and backward. Left is narrower than the right. Left is narrower than the right. Central position, 4 well-marked diagonal bands come out of the central point of decussation intersections located in front of esophageal opening. In front of esophageal opening here. So they are in this way, the middle leaflet, right and left leaflet, and the central point, they form the central tendon of the diaphragm into which the diaphragm muscle fibers they are inserted. So this is the insertion of the diaphragm. Action, when it contracts, it flattens the diaphragm. Vertical diameter of the thoracic wall increases, helps in inspiration. Quiet breathing, 1.5 centimeter movement. Deep breathing, 6 to 10 centimeter movement occurs. Depression of the diaphragm. Expulsive act, sneezing, coughing, laughing, crying, vomiting, defecating, parturiting, micturition, deep inspiration is the glottis which is closed and powerful constriction of the trunk muscle that helps in raising the pressure in the abdomen and such. For example, if we see in the thorax region, first the glottis is closed during coughing process, and there is expulsive force by the diaphragm, contraction of the abdominal muscles, and which pushes the diaphragm upward. Then suddenly the glottis is opened and the cough is done. But in case of defecation, when you try to push out the stool out of the anal canal, increases the pressure in the abdominal wall by contraction of the diaphragm and the abdominal muscles, but at that time glottis is closed, so not allowing the lungs to deflate. So pressure in the abdominal cavity is increased, helping in the defecation. Nerve supply, motor nerve supply, right and left phrenic nerve, C3, 4, 5. Sensory, from the parietal pleura and peritoneum covering the central part of the surface of the by the phrenic nerve. Peripheral part is by the 6 intercostal nerves. So it's a sensory one. So phrenic nerve is both sensory and motor. Motor to the diaphragm and sensory to the parietal pleura and peritoneum covering the central surface of the diaphragm is a phrenic nerve, but peripherally it is supplied by the 6 intercostal nerves. Here we see the main openings in the diaphragm. In the previous slides, if I go back, show you openings here. So you can see main opening is, here is one opening which is for the inferior vena cava. It is slightly towards the right side of the central tendon. Another opening which is covered by the right and left crust of the diaphragm, and also here is the fibers of the left crust. They are moving towards the right side, creating a sling around the esophagus. Here is the opening of the esophagus, and most posteriorly here is opening for the aorta. Actually, aorta is not coming through the diaphragm muscular part, but it is behind, it is covered by the fibers of diaphragm anteriorly. So now we see the openings. Aortic opening is at the T12 level in the median plane. It will transmit the aorta, thoracic duct, and azygous vein. Esophageal opening is at the level of the T10 to the left side of the median plane. So here is the esophageal opening. Then is it transmits esophagus, right and left vagus nerve, left gastric vessels, lymphatics from the lower third of esophagus. Caval opening at the level of thoracic vertebra, 8 to the right side of the median plane. Here is the right side of the median plane. It will transmit the inferior vena cava and right phrenic nerve. You see that left phrenic nerve will come through the diaphragm, not associated with the other openings. These are the main openings. There are other small openings in the diaphragm other than these, which are smaller one, not mentioned here. That is for the passage of the left phrenic nerve, passage of the small, when the phrenic nerve comes to the abdominal surface of the diaphragm, because it supplies the diaphragm from abdominal surface, not the thoracic surface, and also the musculophrenic artery which comes to lie on the diaphragmatic surface, that is supplying from the diaphragmatic surface. They will pass through the diaphragm, and also there may be the and also there will be the congenital openings may be present in addition to it. Here you see on this diagram the openings and levels of the has been shown here. This is for the vena cava, T8 level, esophagus T10 level, and aorta at the T12 level. So inshallah, this is for the muscles of the chest wall, and we have seen this diagram is very important, and we should understand. For the diaphragm, it explains all the structures, the medial lumbocostal ligament, lateral lumbocostal ligament, and also the 12th rib up to the 12th rib, and then from the costal the 11th rib and costal margin, and these are shown the region and insertion of the diaphragm. And we have seen that how many parts, and we have seen here right and left crust of the diaphragm also along with, and we can see here that the another point we have seen is that the medial margin of true crura form tendinous arch over the front of aorta, median arcuate ligament. So here will be the median arcuate ligament. They fuse and passes over the aorta. And then we have seen the intercostal muscles, their actions. Inshallah, in the next lecture, we will discuss about the further arterial supply. Or we have already discussed it, but again, I will discuss something about the arterial supply of the chest wall. Allah Hafiz.